Hi, this is Tom Tolbert, Pulmonary and Critical Care Fellow, and this is a presentation on the use of the ResMed VPAP ST device in mechanically ventilated intubated patients. This presentation was adapted from guidelines developed at Mount Sinai Hospital. These guidelines recommend the use of the VPAP ST for invasive mechanical ventilation only in patients with stable or improving ventilation requirements, and only in the event of a crisis in which there is a shortage of conventional mechanical ventilators. This is a view of the entire setup. Right here we have the VPAP ST device. It is connected directly to an antimicrobial filter, which is then connected to an O2 feed port, and this O2 feed port is attached by oxygen tubing to wall oxygen. The O2 feed port in turn is connected to ventilation tubing that has to have an exhalation port, and on the exhalation port is where a viral filter is placed. A gas sampling adapter is attached to the end of the distal tubing, and this is in turn attached to a GE anesthesia monitor, and having this component in place allows the monitoring of flow, tidal volume, and delivered FiO2, as well as end-tidal CO2. Attached to the gas sampling adapter is an inline heat and moisture exchanger for humidification of the delivered airflow, and this is attached directly to the suction catheter and the endotracheal tube. Appropriately selected patients should have stable or improving gas exchange abnormalities, as in they should have a stable PaO2, or partial pressure of oxygen, over fraction of inspired oxygen, or the P to F ratio should be stable or improving. Patients can be switched from a volume assist control mode or a pressure assist control mode to the VPAP ST as long as they fulfill certain criteria. For volume assist control, their plateau pressure, which you have to check by performing an inspiratory pause maneuver, must be less than 23 centimeters of water. The difference between the plateau pressure and the PEEP, or plateau minus PEEP, this difference is called the driving pressure, and that's the pressure it takes to inflate the lung to the desired tidal volume, driving pressure. That must be less than 20 centimeters of water. Let's zoom in and just look at the pressures on volume assist control in a little more detail. If you have a patient whose peak pressure is 24 and whose PEEP is 14, you don't know the plateau pressure until you perform an inspiratory pause. And you perform an inspiratory pause by clicking this button right here. And what that does is it gives a breath and then stops all flow so that the breath is held inside the patient and in the patient's lungs. And that gives you a plateau pressure. That's this flat part right here. So you have your peak pressure here, it's 24 centimeters. The plateau pressure, which is 22, which should also be displayed on the screen with this notation, P plateau. And this is the PEEP. So your driving pressure is equal to the plateau minus the PEEP, as I said. It's this pressure here, the difference between PEEP and plateau. This is the pressure it takes to deliver the intended tidal volume, the delivered tidal volume. That's the driving pressure. And like I said, that has to be less than 20 in a volume assist control mode. In this case, it's 22 minus 14, so 8. So this patient may be appropriate to switch to the VPAP ST. For patients on the pressure assist control mode, the delivered inspiratory pressure must be less than 20 centimeters of water. And the sum of the delivered inspiratory pressure and the PEEP must be less than 23 centimeters of water. Regardless of what mode of mechanical ventilation the patient is on, the FiO2, the delivered fraction of inspired oxygen, cannot be greater than 85%. And the PEEP cannot be greater than 15 centimeters of water. If patients fulfill all of these criteria and they have stable ventilation requirements and there is a shortage of mechanical ventilators, they may be appropriate for switching to VPAP ST for invasive mechanical ventilation. On the VPAP ST, in order to enter clinical mode to put in your settings, hold down the double check button and the selection knob together for 3 seconds. This will open a screen that allows selection of the appropriate settings. Regardless of what mode the patient starts in, the mode on the VPAP ST should be set to ST. The EPAP, or expiratory positive airway pressure, should be set equal to the PEEP that's set on the conventional mechanical ventilator. The respiratory rate can be set to match the patient's respiratory rate. TI max and TI min should be adjusted on the basis of whatever respiratory rate is set according to this table, which is also available in the guidelines. If the patient is being switched from volume assist control on the conventional mechanical ventilator, the inspiratory positive airway pressure, or IPAP, should be set equal to the plateau pressure. If the patient, on the other hand, is being switched from the pressure assist control mode on the conventional ventilator, the inspiratory positive airway pressure should be set equal to the sum of the PEEP and the delivered inspiratory pressure. So in this case, it's 14 plus 8, or 22. This is a anesthesia monitor that has been specifically set up to monitor the flows, volumes, and inspired and expired gases using those gas sampling tubes that I showed in the setup slide. The peak airway pressure displayed here and here should match the set IPAP, and the EPAP should be equal to the total PEEP as displayed here and here. If these aren't equal, if these pressures are less than the set pressures, there may be a leak, and the circuit should be investigated to find any leak or possible deflation of the ET tube. You can verify that the appropriate tidal volume is being delivered in multiple places here. You can also display tidal volume on the VPAP ST itself. If you press the I button and turn the selection knob, you should be able to find a screen that looks like this that displays tidal volume. Because it's also displayed on this screen, you should be aware that the leak is not zero. There is an intended leak through the circuit, and that's through that exhalation port that is filtered through the viral filter. So it's not zero, but it will display zero here unless there is more leak than what's intended. So if this doesn't say zero, there's more leak than the intended leak, and the whole circuit should be investigated for any breaks, any evidence of leak, including deflation of the endotracheal tube cuff. The delivered tidal volume will be determined by the driving pressure. In this case, the driving pressure is the IPAP minus the EPAP, which should be approximately equal to the peak pressure minus the PEEP. If the tidal volume is inappropriately low, the driving pressure has to be increased. And this can be done by increasing the IPAP in increments of 3 to 5 centimeters of water at a time and monitoring what tidal volume is delivered. However, the maximum IPAP is 25 centimeters of water. So as soon as you hit 25 centimeters of water, IPAP cannot be increased anymore, and the only way to increase driving pressure would be by decreasing EPAP. So if you're already at an IPAP of 25 and you can't go lower than that, then you have to decrease the EPAP in order to increase the tidal volume. And again, it should be done in small increments of 3 to 5 centimeters of water at a time at most. On the other hand, if the delivered tidal volume is too high, say more than 6 to 8 milliliters per kilogram of ideal body weight, the driving pressure needs to be decreased, and this can be done either by decreasing the IPAP or increasing the EPAP, right? That should make this difference smaller. That'll decrease the driving pressure, and therefore the delivered tidal volume will go down. The guidelines recommend changing those values by no more than 3 to 5 centimeters of water pressure at a time. If the delivered tidal volume is already in a lung protective range of 6 to 8 milliliters per kilogram of ideal body weight, consider adjusting instead the respiratory rate if possible. If the respiratory rate is under 35, it can be adjusted upward to increase minute ventilation if the desire is to improve CO2. The delivered fraction of inspired oxygen is displayed here, and it is a function of the liter flow given from the wall oxygen through that oxygen port I showed in the setup slide. You should start with the liter flow from the wall oxygen at 15 liters per minute and see what the delivered FiO2 is and adjust from there. If you require more than 15 liters per minute, you can increase the flow, but you won't really be able to monitor the liter flow, though you should be able to see what the delivered FiO2 is. And obviously, if the delivered FiO2 is higher than desired, you can decrease the liter flow from the wall oxygen. I would suggest changing this only in small increments and seeing what the changes in the delivered FiO2 are. Changing IPAP or EPAP on the VPAP ST can affect the delivered FiO2, so any changes you make, make sure you monitor the FiO2 closely.